Hi, everyone, and welcome to the Q&A session on mantle cell lymphoma. My name is Antonella Rizza, and I'm the CEO at Lymphoma Canada. I'll be the facilitator for today's session. I'm pleased to welcome here Dr. Mary Margaret Keating, who is a hematologist at the Queen Elizabeth II Health Sciences Centre and an associate professor of medicine at the Dalhousie University in Halifax, Nova Scotia. She will be answering your questions as a follow-up from the breakout room discussion on mantle cell lymphoma, which was fantastic, by the way, Dr. Keating. And also sometimes we'll refer to it as MCL. That's just a short form for mantle cell lymphoma. As a reminder to our audience members, at any time now, you can type your questions into the Q&A or the chat box, which can be found in the middle of the black toolbar at the bottom of your screen. We'll try to answer as many questions as possible. And if there are those that are unanswered, we have some Ask the Specialists programs that are coming up in the next couple of weeks, and we could always send them there, and you could attend those webinars live as well. So welcome, Dr. Keating. Thank you for being here, and let's dive right into the questions. And we've got our first one. Okay, so I've been on a watch and wait approach for 5 years now. What is the typical duration for this strategy in mantle cell lymphoma before treatment is usually initiated? To be honest, this approach feels like I'm waiting for bad news to hit any day.
Yeah, so really challenging. So it's unusual. Many patients with mantle cell do need treatment right away, but there is definitely a group of about 10 to 15% who can wait sometimes years without needing treatment. I have one patient who's been 10 years on watchful waiting with mantle cell lymphoma, which is very unusual and not the typical. But some disease is just much more slow growing than others. And I think the hardest, so it is the right thing if you're not symptomatic and your doctor feels it's the safest thing to do, it's better to defer therapy if you can, and it's safe to do that. But if you look at the average mantle cell lymphoma patient, they need treatment usually within 6 months. So if you are on the longer side of that, it's very difficult to predict when you're going to need treatment because you're already longer than the average. And the main thing to do is just to have regular follow-up. And I do reassure patients that they worry, oh, we're just waiting for my disease to get worse to be treated, and isn't that bad to wait for it to spread? But what we do know is that these diseases are very sensitive to the treatment when we give it, and the response rates are very high. So if it's in 10 lymph nodes instead of 3, or if it's in your bone marrow or blood and it wasn't originally, it doesn't mean it's not going to respond well to treatment. But that is hard for people to understand. So it does sound like you're on the longer end of things, but that makes it even more difficult to predict when you may need treatment.
Yeah, Lymphoma Canada, we often hear that the watch and wait approach is referred to by patients as watch and worry, but it is proven to be sometimes better than starting a treatment regimen right away. So thanks for that answer. The next question I have is from someone that says, are there studies for first-line treatment that do not use any chemo since there is such encouraging data using BTKs?
Actually, as I was making my slides and doing my presentation, I wanted to put in another slide of another study, but I was running out of time. And we had a study open. It's done enrolling now, called the Traverse clinical trial, that was looking at this very thing, and it was looking at patients who were eligible and ineligible for like transplant, older or younger patients. I guess we're not really saying transplant that much anymore, but any patients, and they're receiving venetoclax, so the BCL2 inhibitor pill, a BTK inhibitor with acalabrutinib, and rituximab. So it's the first strategy that I've seen in a trial where we're using a chemo-free approach for newly diagnosed mantle cell lymphoma. So that clinical trial has finished enrollment and it's in follow-up phase now. So that's a very interesting study. So that is coming. It's a little bit earlier in research, but certainly something that we're all very interested to see how it's going to go. And I did have patients on that trial who are still doing very well because there's still toxicity issues with other drugs, but just a different side effect profile.
Okay, great. Next question is, I was diagnosed as leukemic phase non-nodule MCL with TP53 mutation. The treatment has only been acalabrutinib and rituximab since March 2024. I see in here all the treatments tend to include bendamustine. Is there some reason why this would not have been included?
Yeah, so difficult to know without knowing your case. We wouldn't be able to do that in Nova Scotia, like funding wise, we wouldn't be able to use a BTK inhibitor like a acalabrutinib upfront if it was the first treatment. I don't know if this was relapsed or first treatment. So we wouldn't be able to use that treatment. We can only use BTK in second line unless it's on trial. But if this was first line, there may have been some special access that your physician was able with TP53 mutations, that maybe chemotherapy may not be the best option, and having a chemo-free approach may be better. No solid evidence on that, but I suspect that's why they didn't choose the acalabrutinib, or maybe based on your blood counts or other risk. But it wouldn't be typical, and it's not a regimen that's funded necessarily in Canada. So I do wonder if you're on a compassionate program or
It was
and have
a
the rituximab from different places.
it was a first treatment remission within 90
Yeah.
days.
Yeah. No, I mean, very effective treatment, no question. I mean, a BTK inhibitor and rituximab would be excellent treatment, just not funded standardly. But TP53, we do worry about early relapses on chemo alone. So I suspect that's why your physician chose that.
Okay, great. The next question I have is there a hereditary or familial component to mantle cell lymphoma? Do family members have an increased risk if I was diagnosed?
Yeah, so really good question. We are learning more about that with time. And we don't have specifics for mantle cell, but we do know that patients who have any type of lymphoma or myeloma, which is another related blood cancer, first degree family members have about a twofold increased risk of developing a blood cancer like lymphoma or myeloma. But the absolute risk is very low, meaning it doesn't mean your first degree family members like children, brothers, sisters, parents have a super high risk to develop those things, because the general risk is quite low. So they just have a slightly higher risk than a patient who doesn't have a family member with that disease. So I tell people there's no special screening per se, but it's an important part of your family history. So your family members should be aware of that. And if you have a sister who develops a lump and you have lymphoma, like she should go to her doctor and say, hey, my sister has mantle cell lymphoma, like I'm worried, could I have the same thing? So it's not common, but there is a slight increased risk, but no routine screening recommended. If we take a very good family history when we see patients in Halifax, because we have a hematologist who does specific research in inherited blood cancer. She's the only one in Canada who does this research.
Wow.
And so she's trained us very well to take very good histories for lymphoma, other blood cancer, or just other general cancer history. And if we have a patient who has two first-degree relatives with certain types of cancers, we can offer for them to see her, and she can do genetic screening and whatnot. So we're fortunate in Halifax to have her, Dr. Amy Trottier, who's done a fellowship in inherited cancers. But a lot of what she's doing is research to discover more. We know that there are some hereditary predisposition to develop cancers, including lymphoma, but we're just at the early stages of learning more about that. But the risk in general is not high. But we do have some families that we see in Nova Scotia, I'm sure similar other places, that you see lots of different lymphomas and myeloma in the family, and there's something in the family that's predisposing them to that. But in a general family, if there's not a strong family history of other similar cancers, then likely the family risk is just marginally increased from a usual person.
Okay,
Yeah.
great. And that's some interesting research that
Yeah,
she's
we're
doing.
very lucky. Yeah, it's very interesting.
Yeah, the next question is, I was recently diagnosed with mantle cell lymphoma. How often should patients like myself be monitored for disease progression or recurrence? I hear some patients are 3 months, I'm every 6 months. And what does monitoring mean in terms of what tests I will be receiving?
Yeah, so this is a variable answer as well. It depends on how worried your doctor is about you, how your original scans and blood work look. Mantle cell, usually most physicians would probably want blood work every 3 to 6 months, again, depending on how much history they have. Visits to the actual clinic with your doctor or over the phone sometimes we'll do, depending on how people are feeling and how far away they live. Every 3 to 6 months is very reasonable. Rarely less than that, again, it's a discussion between the physician and the patient, and what makes them more or less anxious, and or what, and knowing that they can reach out. I usually tell people it's unlikely you're going to be symptomatic the day before you come in to see me. So usually if I haven't heard anything from you and you haven't heard anything from me, it usually means that things are probably going okay, unless there was a recent blood work that we needed to review. But patients should be encouraged to call their clinic if they're having, I always say, any new, unusual, persistent symptoms. So back pain that's new, you've never had, and then it's not going away and getting worse. That is something we'd want to know about. A lump that's growing, and we would want to know about. Blood work changes, we will be following. So always do your blood work on time. We will call people in early if their blood work, if we're concerned about something, that we want to see them earlier for, for a checkup. The problem with lymphoma, the difficulty is it's not just, oh, this is the only thing you need to watch for. Just any significant changes in your health. So that could be weight loss, that could be vomiting, that could be belly pain, that could be back pain, because it really depends on where the lymph node is that's enlarged, or the spleen that's enlarged. That any of those could mean that the lymphoma is causing some difficulties. Um, but if something comes and then goes, say you get a pain in your arm and then it goes away 3 days later, well, we're not too worried that that's going to be lymphoma. But it's the persistent and worsening that it should be at least thought, could this symptom be from my lymphoma, or is this just a muscular strain in my back?
Yeah, and
So,
I think that's great advice, Dr. Keating. I often hear from patients that are worried about bothering their doctors and saying, well, I'll just wait. Well, what harm could it do?
mhm.
And so whenever there is something new and it's kind of hanging around a little bit longer, we always
Mhm.
encourage for patients to reach out as well. So
Yeah.
thanks for that advice.
And definitely okay to see your family doctor as well. Like, if you have a bit of back pain, you think it might just be arthritis, like family doctors can be very helpful, do the initial workup, and they'll often send me a note saying, "Oh, by the way, I just saw, so and so, they came in with this issue. I'm doing just general workup, but do you think
Hmm.
this could be their lymphoma?" And then, I'll look at what they've done or what the issue is, and either it's very clear that no, I can reassure them, I'm not worried at all this is their lymphoma based on we just did a scan 2 weeks ago or something. But if I'm not sure, I'll usually say, yeah, I think I should see them, or, my nurse will give them a quick call, and maybe we'll order an extra scan if they're having pain that's not going away, for example. Then, so it is hard because it's so many, it could be many different things. But the key is something that's really not going away, that hasn't been investigated before. Like if you've had back pain your whole life and it's the same as it's always been, it's
Right.
less likely to be an issue, but something new and persistent.
Okay, wonderful. The next question is, I am starting treatment with ibrutinib soon. What are the most important side effects I should be aware of, and how can I manage them?
Yeah, so ibrutinib is one of the first generation BTK inhibitors. Excellent drug, really revolutionary for mantle cell, as I mentioned in my presentation. Um, in all of those medications, those pills, sometimes when people start the medication, they can have sometimes a transient headache for a week or two, a little bit of diarrhea. But longer term, the sort of unusual potential side effects are 40% of people notice bruising, like they notice that they bruise easier, that they get little red spots on their legs, like little teeny tiny dots, because there is a mild bleeding risk with it. So that's moderately common. I tell people that they can get bruising. 10% of people can get atrial fibrillation, where the top of the heart beats faster than the bottom of the heart. That's not a life-threatening heart rhythm, but sometimes can present feeling your heart racing. And then sometimes we need to put you on some medications to manage that if it occurs. And over time, high blood pressure can develop with these medications sometimes. So we always check blood pressure in the clinic and have people keep an eye on that. Otherwise, there's always some risk of infection, some risk of low blood counts. But generally they're fairly well tolerated, and people are usually on them for a few years if they work well. Um, yeah.
Okay, great. The next question is, in which clinical scenarios would you recommend a second generation BTK inhibitor over a first generation agent? And what factors guide that decision?
Yeah, it's really challenging. It's because right, they're all good. So I have patients on both. And certainly when ibrutinib was all we had available, that's what everyone used. And that is all that is funded right now in Canada, like by provincial, programs. But zanubrutinib has a compassionate program, and I'm not sure if acalabrutinib does off the top of my head. So the other second generation. So you can get those drugs often, the second generation ones. So they all have the same list of side effects. The first and second generation have the same list of potential side effects generally. But the percentage risk, especially for the atrial fibrillation, is lower with the second generation. So often, but not always, physicians will try and get a second generation if we can, hoping that might be more tolerable potentially, or the risk of side effects is lower. But that doesn't mean choosing a first generation is wrong. I just started someone on a first generation last week because we can now get it in combination with venetoclax, like with a new compassionate program. So now I might be reaching for ibrutinib even more because I can use it with another drug. But it really depends on the situation. Are you worried about specific heart things with your patient? Have they been on ibrutinib, had troubles before? Are you trying to use it in combination with another medication? But they're all very good medications. And sometimes it's a bit of a flip of the coin because they're all very good, so it's whatever one we can get easiest and is covered in your province.
Okay, and someone just asked, what does compassionate program mean?
Yes, sorry. That's when a drug is Health Canada approved, like the government has said, yes, this works, we can use it in the country, but not funded, meaning the provincial programs have, for whatever reason, said, we don't want to pay for this drug. We don't feel it's adding more to what we already have. So then often drug companies will say, hey, look, I know they said no, but we will still let you use this for free. So the drug company, we have to sign people up, and the drug company will give the drug out for free. So compassionate programs most commonly occur when a drug is in between those phases, like meaning the study's been done, it's a good study, it's been approved by Health Canada, and it usually takes 1 or 2 years for the funding to come through, or the decision. And so during that time is the most common time for drug companies to say, hey, look, we're going to give you this drug for free until we know if it gets funded or not. And people will say, well, why would they do that? I mean, drug companies, they do still want to make money. They're doing their thing. They're trying to get new drugs to us. But the earlier we all learn how to use these drugs and be comfortable with them, and then they get funded, probably the more we use them as physicians, right? So, I mean, I do think that, there's a reason they do this. They, one, want to help the patient population because it's what they're studying. But two, the quicker physicians understand the combinations or the drugs, the more likely they'll use them and understand them and understand the side effects. And that's important, especially in places where they haven't had the clinical trials open. So a lot of the mantle cell combinations and whatnot, we've had the trials open. So we're very familiar with how to use the combinations. But it just basically means you can get the drug for free. And there's no stop date to that. So these compassionate programs do open and close, though, meaning once you start on the compassionate program, you'll always get it. Typically, they don't usually close it and take it away from you. But if they're no longer allowing enrollment, then you can't get it. So a program will close and they'll say, okay, we're not offering this to any new patients. So it's a bridge usually to funding is typically what it is. Yeah.
Okay, great. The next one I have is, I've been experiencing significant fatigue following my rituximab injections. What strategies or approaches can help manage this side effect?
Yeah, really tricky because fatigue is so hard, and obviously without knowing you as a patient. But a lot of my patients have fatigue, and I think it's multifactorial: the drugs, the disease, all the stress going through with everything else, whether or not they have any other health issues. I just encourage patients to try and get good sleep, try to eat healthy, limit alcohol. Try to get exercise, sometimes to push a little bit, like try to get for a walk, but then rest if you need it too, right? So there's not, unfortunately, today a patient's like, what do you mean there's no pill to make me feel better energy wise? We wish there was. We wish there was something that would just give people more energy, because that really, it makes people sad, right? That they just don't have the energy to do what they used to do, and they feel like they have to have that afternoon nap when they didn't used to. So unfortunately, I don't have a quick fix for that. Obviously, we check the usual things, check the B12, check the iron, make sure there's not something else, check the thyroid, make sure there's not another reason for someone being fatigued. Actually, the other day I found one of my myeloma patients had B12 deficiency, and he was saying, I'm so fatigued. And I said, well, let's just check all the routine stuff because your myeloma is doing well. So could be the drugs, could be the disease, could be just, other things, but no quick fix. Good to
Yep.
just make sure the physician knows how you feel so that they can think about those things.
Absolutely. And
Yeah.
for anybody that's here today, under our resources tab, there is a resource that we have on dealing with chronic fatigue. And you can download that right into your swag bag, and it could get emailed to you if that's helpful at all. So the next question is, in patients with early relapse after frontline therapy, do you think a combination approach is better, CAR T or clinical trial? What should I consider?
Yeah, so it depends on a lot of things. And so that's, again, good to talk with your primary physician. It depends on what treatment you got the first time around, your age. The CAR T is usually third line onward, depending on what agents you got. If you got a BTK up front, you might be eligible for CAR T if you were on a trial and got it that way. But CAR T would usually be for third line. Second line, the most common would be ibrutinib or like a BTK inhibitor. And rate now in Canada, that compassionate program for ibrutinib and venetoclax just opened. And that study, which we had open at our center as well, did show improved remission times with the combination versus the single agent ibrutinib in relapsed mantle cell. So that is a reasonable option depending on your history. And a clinical trial, a well-designed clinical trial, in my opinion, if your physician feels that's a good option for you, is always a good thing to consider. Because when we talk about clinical trials with patients, we're always talking about this is our standard of care we have available. This is the trial available. These are the pros and cons of each. So hard to say. CAR T usually isn't until third line. So if you have a combination available that your doctor has said would be good for you, then that might be an option. But single agent ibrutinib or acalabrutinib or zanubrutinib would all be reasonable options at second line.
Okay, one of the questions that came in is, can mantle cell lymphoma treatments cause congestive heart failure? I had none before, but it showed up 7 months after treatment started with acalabrutinib and rituximab.
So hard to know. So if you've never had CHOP chemotherapy, so one of the chemos in CHOP, doxorubicin can cause heart failure, but it sounds like you haven't had that. BTK inhibitors, this is the acalabrutinib, ibrutinib, are funny things in that, and I'd have to relook up the monograph. So generally, we don't consider them to cause a reduction in the heart pumping muscle. There's different types of heart failure too, so I don't know if it's a problem with the muscle or pumping or relaxing, so two different things. But generally, no, I guess is the short answer. Like we don't routinely do an echocardiogram or a heart test before you go on these drugs. And typically, if that's a concern, we would do that routinely. That being said, rarely heart rhythm troubles other than AFib happen with these drugs. Or if you've had high blood pressure over time, that can lead to stiffness of the heart, and that can cause troubles with heart failure sometimes. So generally, no, but it would be situation specific and depend on what the heart doctor thinks. And
Yeah,
yeah.
I think they had mentioned it's a diastolic pump.
Right. Yeah. Diastolic would be a more common form of heart failure, congestive heart failure. And so the most like women, older people, people with high blood pressure chronically can be at risk for that. So diastolic heart failure generally would not be related to any of the medications you're receiving. But maybe if your body was more stressed and going through things, it might be more likely to come up after treatment potentially.
Okay, great.
I,
And we've got just a few more minutes left, so I'll address one last question. There are several more that have come through via our info at email or through the chat here. What we'll do is, if they're not answered today, we'll take those. We have an Ask the Specialist session that's coming up on October 30th. We'll feature those questions there. So if you'd like to sign up for that webinar, you can go to our website at lymphoma.ca, and we'll get the rest of these questions answered for you. So the last one for today is, you mentioned a few clinical trials in your presentation. What is the process for getting involved in these?
Yeah, so from a center to center point of view, like we have to choose to open a study. So I choose a lot of the lymphoma studies for our site, especially for mantle cell. And so I usually either hear about a study going on, or the company or whoever's running the study comes to our site to say, hey, would you like to open the study? So we're looking for a trial that is going to benefit our patients. Like, we're not going to open just any study. We're
Right.
looking for drugs we want access to that we don't have access to, or in certain lines of therapy. So we've had multiple 3 or 4 different studies for mantle cell with BTK inhibitors up front, or combinations in relapse disease. And so we have to choose to open it. And then all the physicians at our site know what studies we have open. And so if they have a mantle cell patient, we always say, come to me and ask me, do we have any studies right now that would be good for a patient? And I'll say, oh, yes, we have this really good upfront study. And then that gets presented to the patient as this is a study option. This is the standard of care option. These are the risks of both. Patients have time to think about it. They take the consent form home. And then if they want to be screened for the study, they sign the consent form, and we go through the screening process, which we have 28 days to do, meaning people often have to have bone marrows and CAT scans and blood work. It's typically what would be standard usually. And then if they meet all the check boxes for the study, like you have to have good organ function and have mantle cell, obviously, and then the study starts. And if you're at a site that doesn't have a lot of clinical trials open, then you would have to ask to be referred to a more central site that might have trials, or have your physician reach out to one of those sites. So rarely I'll reach out to Toronto or BC or Quebec to say, hey, I have a patient and I don't have a study for this and they really want to study. So I reach out to say, do you have anything that might be of interest to my patient here in Halifax? That would be more rare to move around for a study, because then you have to be there for all the treatments.
Right.
And
Yeah.
that's hard. You can't be treated at your home site once you're on a study.
Well, I appreciate that answer, and thanks again. To conclude this session today, I'd like to thank Dr. Keating for taking the time to participate in today's Q&A. It was invaluable, and we hope that everybody's gotten their questions answered. We hope that those watching today learned something new about your or your loved one's lymphoma subtype, mantle cell lymphoma. With that said, please tune in to the next session titled Accessing Clinical Trials in Canada, which will be starting shortly. Thanks everybody for joining, and thank you, Dr. Keating,
Thanks.
again.